I have a substantial conflict of interest. The highlight of my professional career was not working at UW or something like that, but I got to serve as a surgeon volunteer in Ramstein and Landstuhl during Gulf II, and it was an unbridled, amazing experience. Humbling, gives me still chills. And those servicemen and women, wounded warriors, were incredible. Their three questions were always the same. What's the injury? What can you do? When can I go downrange? And the quality of interactions with them, and if possible with their families if they're stationed overseas, like in Germany, was amazing. So felt extremely gratifying. In terms of America, there are many questions raised about where this country is going and who we are, and there all that mattered was ability, affability, and rank, and in reverse order. And it was just deeply gratifying. So I'm heavily conflicted and recommend anybody consider this kind of a service. So my perspective is heavily tainted towards the academic side, and I'm in a private academic setting since 8 years. And again, there are many different spheres in which we can work. And of course, there's obviously an administrative, a medical, legal, and an industry consulting area as well. All of us strive to have great patient care, make a reasonable living, or good living, or great living, but enjoy a good life, a meaningful life. This is the academic trifecta that we all know of all too well, and this is the subject of my talk, how to kind of make this happen: education, research, and patient care. And the academic value proposition here, and this goes to Jonathan. Do you know the seal of this great university, Jonathan? Do you know this university? Who knows which university that is? Anybody? 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 Huh? Harry Potter, Hogwarts, the ultimate, right? So you can magnify yourself by associating yourself with a great reputable brand like Hogwarts. You can make a positive difference through education and research and participate in a great pool of talent. The real academic trifecta, however, is seen through the lens of finances. And again, one of those is truly seen as medicine has become a business, the greatest transition of 2000, by the way, that affects medicine, the transition to business enterprise, that is. And that's patient care. Research can give you some funding. Education literally does not. The bigger picture for an academic surgeon is the rat race or the hamster wheel phenomenon. You have a 2-year kind of a grace period in which you're supposed to get started. But ultimately what matters, and I say it as an ex-UW professor and chair, is that you have to meet your RVU goals. It's all RVUs, so the contrast to your lecture could not be more poignant, and you could have not prefaced this lecture better. It's all RVUs. And whatever they say in publications, yes, you have to meet academic goals within 5 years, usually around 10 papers where you're first, second author, or senior author in selected journals. You have to get a certain number of grants. And you have to meet educational goals, which nowadays means that you have to collect teaching evaluations, the academic form of Yelp reviews, from everybody who's been around. So if I was still in an academic rat race, I would hand you paper sheets and have you, or give you emails to score me and see how that goes. Only once you have reached associate professor standard can you kind of expand your horizon, can you kind of rest easier. The other thing is that, and this fits into what Peter talked about earlier, you have to serve on committees. And so the de facto thing is that it's actually an academic quadrifecta with committees, which are absolutely unpaying things. So they're an enormous burden in terms of time commitment. They're absolutely essential in terms of political entrenchment and understanding the mechanisms, and they're completely free of charge for you. So they're a complete RVU neutral or negative thing. So basically, you have 5 + 1 years usually, fudge year is included, to accomplish a budget-neutral, at least RVU collection setting, fulfill the academic productivity criteria, which are institutionally different and should be negotiated beforehand. You should have a habit of collecting your solid teaching evaluations and develop a hospital systems reputation and political clout. So in one word, so many things to do, so many things to see. So what are we going to do next? And this is, again, a lesson in learning to manage distractions, which I think is the biggest thing that differentiates differentiates academic practice from all the other practice entities. And it is very easy to get lost. In orthopedics, I have some pretty hard numbers. The survival rates, and I'm not a survivor in that sense, although I'm a professor at Washington State University, I'm proud to be so, is about 40% of academic surgeons in orthopedics stay for the duration of their career. Most get out and change practice, such as I did 8 years ago. So the main problems in academia are that there's not a question that the clinical productivity is decreased. There are a lot of cogs in the wheel. And again, this is where military medicine and my experience, and that includes 10 years serving at our VA, is just decreased. It's just not the same despite best intentions and always being made to feel guilty and adjudicated. In general, also, and this is a tough thing to say, I'm not going to underscore this, so view this as a statement of mine, complications are generally higher, and you generally serve a mission population, or a greater proportion of a mission population. The work teams are also ever-changing. This is sometimes really fun, and sometimes when you do very kind of routine procedures can be quite agonizing because your expectations are obviously that good things at work are done the same way. You also have trainees in all stages of care delivery, and just to quickly change your lens from that of a provider or industry member to a patient, when you have at every single interaction the usual kind of a progression of student to junior resident to senior resident to fellow to finally attending sometimes, the redundancy of this gets pretty annoying. And so just as a little sidebar from several of my good friends who've gone through this, so this is something that you have to kind of learn and live with as a surgeon leader sort of as well. And there are protracted learning curves due to these randomnesses of interactions. The overall, and this is a relatively hard number that we had used at UW, efficiency, productivity, complication differential hovers around 15%. So relative to a well-oiled machine, the best run academic hospitals usually have a deficiency in most metrics of around 15%. That's the academic 15%. So frustrations from the individual are that you're dealing with a multi-layered hierarchy with complex changing politics, there are built-in systems inefficiencies, and there's also truly for young attendings a lack of meaningful startup support with a continuously changing cast of characters. So you have this 5-year clock, and you have a pretty substantial bureaucracy that you're dealing with, which changes its face. Also talking about Geld, the money part, this is a steeply hierarchical comp structure. It's very incalcitrated into the system. There's also a relatively poor correlation between clinical work effort and earnings. Incentives are usually capped, especially at state institutions. It's different in some of the private institutions, but all state institutions have incentives that are capped. And the income differential to private practice is usually 50% or way, way worse. Outside consulting as an additional income source is possible, but usually not encouraged. It's actually discouraged, and again, it's severely capped. And royalties are highly contested and very problematic unless you're really well set up. So what can go wrong in this whole academic treadmill? Well, you can really burn out pretty rapidly. Surgeon burnout has been statistically probably overinflated, but we have to think that roughly 60 to 80% of surgeons have burnout, and this can take very severe forms, even to the point of suicide. There may also be a simple lack of talent fit. So the respective institution may have a very different set of resources and abilities that may not match yours, and you may be a great surgeon, but you may not be the best researcher, you may not be the best educator who can handle the various needs of their target population. So this is a real challenge. And then your own priorities may change. And I have not even talked about the top priority, which should be you and your family. So without a question, those priorities do change. So a lot of people do have this feeling that they really kind of just want to kind of chill and not do this rat race. And if you feel that you're like one of those hamsters in that top right picture, it's probably not the right way to go. So who does this? The top 10 reasons that I've come out, and again, I have had the great pleasure to have friends and mentors like Alex Vaccaro and Michael Failings. You have to have a certain mission drive. These jobs in academia do provide you a modicum of job security. I was a fully endowed and tenured professor. There's a pre-structured development path, which is relatively accountable for. If you're a highly organized multitasker, you'll find this a really gratifying thing. So I'm ADD, and so this is kind of this endless kind of changing of task scenarios is kind of cool. Challenging surprises are never ending. To be told on your stair walk up at 6 a.m. that by mistake, an intern from another service removed the sutures on your post-op day 1 patient in a posterior neck surgery, it just never ends. If you want to make a lasting difference, yes, there's a clear legacy of pyramid effect. And so I've had probably over 100 fellows now, and this is a pretty cool network of people that I enjoy interacting with. Yes, and maybe to some degree you're an attention seeker, so that goes for myself. Maybe I'm seeking pathological attention, but you certainly can't shy away from attention. There's an undeniable meetings and travel benefit, and personal preferences obviously are heavily redeemed in this regard. And if you have a reward-driven personality structure, that clearly fits. So in summary, the 3 profiles of success are personality traits, organizational reputation, and individual determination make an academic surgeon. The ultimate rewards are honestly non-material. So there's a true potential for a transcendental exposure. So we have a very talented young German fellow here, and he's going to make his mark in terms of changing how we treat musculoskeletal infections. I have no doubt. With classifications, Dr. Plumer has a very cool grasp in a multi-specialty way. You can challenge yourself in ways that you never imagined, and there's an undeniable fact for personal growth. So for instance, top left, this is one of my heroes, Jeremy Fairbank. There's few things better than basically getting to see your favorite baseball team at Fenway with one of your favorite people, Jeremy Fairbank from Oxford, who developed the ODI, by the way, a little trivia point. So these are kind of the real rewards, and they're immaterial because there is clearly a rat race. So this is just a little thing looking back. We just recently talked to those fellows, 2019. Academics, private-demic, and private, and basically most of them actually chose an academic pathway. That's kind of really cool to see. Some went into private-demics, and one guy went into private. And you know what? I wouldn't care if it was the reverse ratio, but despite seeing and hearing these sentiments about academics, most of them still went into academics. That's kind of cool. So as a summary, so in terms of practice control, as surgeons, we have to have a certain degree of control obsession. There's little doubt in a true private practice, the surgeon is the boss. Somewhat diminished in private-demics as you're working for a large system, as I'm experiencing. In academia and in government service, I think it's fair to say you have very little individual practice control, and Wayne is nodding his head affirmatively. In terms of work effort, in private practice, you have a strong, in nature due to the private practice control environment, you have a very measured work effort. It can be super hard, but if you don't want to be super hard, it's your call. In private-demic, actually, the system, which is usually a large system, even Jefferson with TG, with the Rothman Institute, they have a certain kind of a lens through which they gauge you. In academia, again, there is a clear work effort that can be super hard, so this can range from anywhere from 1 to 3 weight scales. In government, there's a highly regulated work effort. So in the VA, at 3 o'clock, there was closed down. And if you were not out of the room by 4 o'clock, they were not happy with you. Fair? Again, that's the same part in the VA system. Income potential is vastly different. Again, this totally echoes what Wayne said. In private and private-demic practice, you can clearly earn way more in academic. It's kind of a trifecta formula that they usually come up with and that few understand. And that's, again, heavily regulated and very different. And academic recognition, again, in private practice is super hard to come by. And again, in government academic services, you have a reputation. The Hogwarts Academy seal of approval gets opened doors far easier. Having been a private institution, you usually don't have that same entry, let's say, for grant applications. And then finally, job security in the rewards section. So job security in private practice can be very low. And in intermediate fashion private-demics, the TBI colleagues, for instance, went through a serious, complete life change when the association with their major payers changed. And academics is pretty high, certainly if you get tenure. And in government, it's usually extremely high unless you have major moral turpitude. What's the upshot? Wanderer, you got to know thyself. Ultimately, you got to know the path that you want to be on, but you should be in touch with yourself to see if this is the path you want to go on. And it is entirely possible to be very happy if you change paths. In fact, it can be quite liberating. With this, I close. Maybe, Wayne, can you come up and we can have a brief talk? Why don't you come up here and we can just talk.
I can ask you your opinion on something that I saw.
You can talk to the microphone.
Yes, sir. I'd like to hear your thoughts too. And one of the things that I saw in academics over time, initially the RVU didn't seem to be the holy grail, but now RVUs has become bigger and bigger and bigger in your academic practice. And I heard some surgeons say, look, I'm not gonna spend so much time teaching anymore. I'm not gonna do these conferences as much because it costs me, there's the 0 RVUs for teaching. What are your thoughts on that? I mean, I think the turnover times of the room is terrible at some centers, so it's harder to get the RVUs, but they're driving the RVU model more and more in academia, and I'm not sure that that's the best answer. What are your thoughts?
Great point, super point. In fact, yeah, stay right here, because that's a fact, and actually this was always the case. Just the gloves have come off, and now it's become a brutal reality. So where it was kind of just shimmied over and glossed over, now where the bureaucrats, the penny counters have really taken over the academic medical centers, it's become a absolute reality. Mm-hmm. And you're quite right. There are a lot of younger partners who just basically go like, I'm not going to do this because it doesn't pay me anything. And all of us in my final years at UW had struggled very hard to look at alternate payment models. And ultimately, what drives the ship is how much your mission margin is. And if that's low, if your yield drops to a certain point in time, you're going to get a lot of pressure from your superiors. So this was always the case, but now it is blatantly clear. And now it's almost the opposite. You have to kind of coerce people, or you have to come up with very egalitarian, not to say communist payment models, which are also kind of counter to a lot of surgeons' motivation. So very difficult subject. There's not a single formula. I know the Rothman, whom we've always looked up on, they had a very interesting formula. Rick, are you still on? Rick Sasso in Indiana. I'd love to hear Rick stop, because he runs one of those very successful private enterprises. He may have had to leave us there. He was on for the longest time.
Campbell?
No, he's at Indiana. And Hyun, you're on. Hyun, can you put a Bay?
Yes.
Tell us about the enormously successful, I don't know how to call Cedars. I think, is it private-demic or is it more academia? You tell us.
No, I think that we have both. So we have private practitioners, and now it's probably like 60-40, where 60% of the faculty are private practice and truly private practice, their own solo practice, and 40% are, hired by Cedars. But no question, we've developed a system where we all participate as one, and that's pretty incredible. So, and it typically is the younger faculty who are the Cedars, hired positions. And, I'm not so sure what's going to happen in the future. I think that, what happens is that, they come in, and the typical model was, we'll hire you at Cedars. And usually they stay for 5 to something years, get established, and then they become private practitioners. They just kind of step out and stay in the community. And there's no non-compete in California. I'm not sure, because the dynamics have changed, right? So I think that the people that are coming out now will get hired at Cedars. They're not looking for a private practice. They'll get hired at Cedars, and they'll stay on. And I think the income differential between, academics being hired versus being in private practice, I just see that, changing. I really, really see that changing, meaning that, there was a time when you can make a lot more during private practice, but I kind of see, that system changing a little bit. Unless you have really good ancillaries like surgery centers and things like that, I think the insurance reimbursement and what they've been able to do, that you almost need the hospital facility fee to subsidize your salaries. And so I see that kind of happening, at least in Los Angeles.
Your program has been one of the most successful ones in the country, maybe in the world even, by combining academics and excellent surgical practice. Do you get any bonus points for doing education like today, or publishing your many papers, traveling across the country to give lectures? I mean, do you get any plus points anywhere in some credit system?
No, just for, Yen saying, hey, those are the plus points, just, having you guys, being a part of your program. I don't think there's any kind of academic recognition or plus points in that regard. But, it's the good thing is that most of the private practice guys that actually do this, do it out of their own enjoyment. It's not some academic goal they're trying to achieve. It's really more of a personal goal of staying involved. Obviously motion preservation is something that, is dear to my heart, dear to Jack's heart, dear to yours as well. And, I think it's just really all out of enjoyment, which is actually a nice thing. When you don't have to do it, but you want to do it, I think that's what we're all trying to treat, right? So, in the short term, no, we don't get anything out of skiers, but in the long term, it's just the camaraderie of being, a part of this, seeing you and seeing Jack and Scott and Armin, discussed in these discussions, learning something about endoscopic surgery, which I haven't done yet, which I think is incredible. But, that's kind of, not hardcore academics, but I do think, that's the ideal that we all try to strive for, whether you're in private practice or, hired by a hospital or a university.
So what drives you is, again, just a genuine fun and reward in terms of interactions and doing things. Why do you do research? You publish a lot. What drives you to do research?
Yeah. So, it's kind of odd. I mean, I'm very inquisitive, probably very similar to you. It's yes, the research didn't go into some, tenured position, but, I guess it's just natural, right? And it's fascinating when I see fellows that come through, I see the same thing. I see people that want to publish papers because, they want to publish papers to get to the next step. And once they get to the next step, they're done, right? They don't publish anymore. But I do see people that really come in that really have, an academic curiosity and they want to investigate, they want to publish, they want to do research. And I think it's inherent. I just, so I think that, if you're that person, yeah, maybe an academic center would fit because you want to do it. But if you're not that person, then, every man for himself. Like, I don't think that those situations fit where you're forced to do it. So, I mean, I've just done it because I've just been, always curious and, wanted to do it because I'm always trying to figure out really, what the true answer is or how can we do things better. But yeah, I ask that myself these days, but it's
your
just,
wife asks you
I guess I enjoy it.
Wayne, does the military keep statistics on where the ex-military surgeons after their service go? How much go into private practice, private-demics versus further government service?
Yeah, not that I'm aware of that they don't keep statistics. There's a lot that go into private practice. I think some of it is to try to make up for the financial aspect. But if I could say something briefly about academia as well, so I was saying the RVU seem to become more and more prevalent. I think, like you're saying, Jens, it was probably always there. There was a formula for people like me who like to publish with the residents. But if I got criticized about my RVU productivity wasn't as high as they wanted, I would look them in the face and say, I do every indicated surgery that there is to do. I do the right surgery for every patient. I spend a lot of time teaching because that's really what we're there to do. I try to lead by example every day. So you go in, clinical excellence, you take great care of your patients, you do great surgeries, you teach the residents and fellows. Really, is that not our legacy? Is that not why we do academia, right? It's not to say I'm a full professor. It's to really shape your field and further and take care of the people who are going to be doing it long after my time. So it's very rewarding. Don't make the decision based only on money. And some of the things you're hearing, the RVU deal in academics, I do think it's gotten a little bit out of control. And I think it needs to be better regulated because it is, to some degree, to the detriment of your RVU productivity, therefore money, which I don't think should have as big a role in your overall success, if you will, as considered as a faculty.
Does anybody in our fellows have a question? Otherwise, I have a final question, and then we can go back into the lab and show a procedure I love that is totally underrepresented. That's laminoplasty. My question to you is, so the military was clearly a pioneer in allowing disc arthroplasties. This is the whole theme of this meeting. This was an amazing thing. I actually had the great privilege of doing disc arthroplasties way early in some of our servicemen and women, and the military allowed that. And then they actually came and testified in our state commission in terms of their results. They came up in person and did very convincing demonstrations of the superiority of arthroplasties and indicated well-performed surgeries. Is there, and here's my question, any statistic in terms of the survivorship and long-term surgical outcomes in these military people who had these disc arthroplasties in these early 2000s?
So we were the ones, I was the one doing them in '04, or really when they first started, '05. So we published our data, short-term and moderate or intermediate, and the results were good. And again, a lot of it was, I think, a selection bias that really enabled people to start doing it and people to say, wow, this looks like a good promising operation. Right now, we are actually going back and looking at all the years of data, and we're trying to get it where they're not letting helicopter pilots get it, but now they're looking at the data to say, wow, and we're doing biomechanics study and showing there's really no reason not to. Fighter pilots cannot get it, but we did them in special forces guys all the time. So I think they are seeing it is a great operation with really long-term success. So we're going to go back and hopefully publish 20 years or nearly 20 years of our data in that population, and it would be hard-pressed to see people on the outside really pushing the limits of these devices like these military men and women are doing.
Yeah, that was a big deal because we could, exactly what you said, we could do it in special forces, but the fighter pilots and our would-be Island pilots, they did not want
They're not allowed.
disc arthroplasties.
They're not allowed to have it. So Navy fighter pilots, which is my population, and Marines, not allowed. If they're in an ejection seat aircraft, not allowed. And then they said no helicopter, and I was like, if you crash your helicopter, your artificial disc is probably one of the last problems you're really looking at. So, but now we're hoping to get that changed.
So hopefully there'll be a long-term study in terms of the outcomes of
Yes,
these
sir.
discs, in terms of
Yes, sir.
reoperations and things like that.
Yes, sir.
Because we don't need a comparison group, but just having that very select population 20 years later,
Right.
re-reviewed, or 18 years later, that would be a very big deal.
Yeah, that's what we're hoping to do.
Well, any other questions? Otherwise, I will step into the lab with Dr. Avila, who's there already. And Dr. Egloff, we'd love to have you in our lab.